The problem is you do see a lot of antisocial people succeed. Loneliness is as big a risk factor for ill health and death.
We live inside our heads.
You go cold turkey, you go into withdrawal.
There is a lot of value in the stuff that we struggle with.
Better Thinking. Conversations with experts exploring all things psychology. Welcome back to Better Thinking. My name's Nesh Nikolic, and my guest today is Associate Professor Jacinta Hawgood, offering her wealth of knowledge relating to suicide research and prevention, which has been used to inform best practice principles to responding to suicidality here in Australia and around the world. Jacinta has worked at the Australian Institute for Suicide Research and Prevention since 2000, firstly as a senior research assistant, and since 2004 as lecturer and currently senior lecturer in Suicidology. In 2000/2001, Jacinta was involved in the development of the Graduate Certificate of Suicidology and Master of Suicidology programs, the first of their kind in the world. Since 2000, Jacinta has developed, delivered and evaluated suicide prevention training for the suicide prevention sector in Australia. Jacinta is the lead author of the Systematic Tailored Assessment for Responding to Suicidality Protocol, published first in 2015 and updated in 2018. She is the coordinator of STARS training workshop delivered nationally and internationally to a range of allied health, mental health, emergency welfare and community workers. She has worked clinically with suicidal people for over 20 years and has supervised other psychologists in this domain for 15 years. Jacinta has a reviewing role for the peer-reviewed journals in this domain of suicidality and has presented research findings at a range of state, national and international conferences. It was an absolutely great pleasure to interview Jacinta and find out the latest research and gold standards in supporting those experiencing suicidality, and also learning about the competency-based training available in Australia for health professionals. A real refreshing look at how health professionals can support people through this very challenging time that moves away from just a checkbox system that is somewhat daunting in that it doesn't necessarily feel like it's enough, but it certainly felt like it's the thing to do for so long. And I think there's a real deviation in the training and competency-based program that Jacinta has worked on for quite some time, and obviously the research is pointing to. So I hope you enjoy this episode, as it's been really refreshing and enjoyable for myself. Jacinta, a big thank you for coming onto the program today. I'm excited to be able to have a conversation and explore suicidality, not only from the research perspective, but also from prevention. And I know that you've spent many years, a lifetime of work in this space. So, really appreciate you coming on today.
Thanks, Nesh. Yeah, it's great to be here. Thanks for inviting me.
Maybe we can start with how you got into this space. It's obviously quite a niche and unique place to spend your energy. How did this come about for you?
Very interestingly, actually, I was doing social science, worked in juvenile justice back in the very early 90s. And I worked my way into, I guess, working with young people who were on probation, and those also transitioning from prisons, or back then we called them delinquent settings, can you believe? So moving from jail to community. We had a lot of, at the time, Aboriginal and Torres Strait Islander losses, which was always very tragic and traumatic. I guess hit me quite a bit. And also knowing that we didn't have any training, in fact, around suicide and suicide assessment, etc., in our studies, postgraduate as well. I did at the same time, when I was working part-time, moved into psychology and completed my undergrad as well as honours and clinical masters. And I was posted because I received a scholarship to go rural remote work when I finished my master's. So I worked out for Queensland Health, out bush, did a lot of outreach to Hewenden, Richmond, etc., southeast Queensland, and then west of Queensland, inwards from Townsville, actually. And that gave me a great appreciation for, I guess, the gaps both in services, but also in my knowledge and competency. You know, after 10 years of university and going out to the real world and still not feeling I was capable and competent in regards to suicide assessment was both disheartening, but also exciting, because at the same time, I came to realise a lot of other professions had no knowledge either, from psychiatry to doctors, right through to social workers and nurses, etc. at the time. So we're talking the late 90s. And at the same time, there was a concurrent emphasis in policy and prevention globally around youth suicide and youth suicide prevention. And Australia was one of the first countries at the time to develop and implement the first ever national strategy to prevent suicide in young people. And so whilst I was working up at Charters Towers, I was visited by members of the Australian Institute for Suicide Research and Prevention at Griffith University, who were trying to obtain an understanding of the needs of rural remote workers and a whole cross-section of, or disciplines, if you like, of workers around suicide prevention education. And they were really keen to talk to me, to other people, and I'd actually just finished undertaking from a really important project, a training project, I should say, Keep Yourself Alive, which was about youth suicide prevention. Came from Flinders University, where Emeritus Professor Graham Martin in Australia, he's quite a high-profile professor who came from the UK to Australia to introduce and focused on he was a child psychiatrist, and focused on self-harm, mostly non-suicidal self-harm, but then increasingly as well suicide. And so at the Australian Institute for Suicide Research and Prevention, I'd already done some research assistant work at the centre before I went out bush entering data. We had the Queensland Suicide Register there, and they were looking for people to engage in this education training project. So I'd just finished this other Keep Yourself Alive training program, which was for GPs actually. But I just was, something inside of me, I was just hungry to want to learn more about it. I guess I felt that I had quite a bit of uncertainty and fear. At that time, it wasn't related to anything legal, and increasingly today, there tends to be in clinicians a fear about legalities and litigation and a whole range of elements, which I can talk a little bit about later, because I want to flag that because it's quite important to my research today. But anyway, it was more about just wanting to make a difference, I think. So anyway, I was very keen to hear about this position that was going. I accepted it. I hadn't experienced my own suicidality or had no lived experience of suicide. And at this point, probably it's, and I'm sorry I didn't say this at the beginning, but it's really important to recognise and acknowledge lived experience of suicide in all the work that we do, in the research that we do. For me, it's become pretty much central to everything I do. I'm realising as I age, after being nearly 26 years, I would say at AISRAP, at the Australian Institute for Suicide Research and Prevention, I've come to appreciate, not just in my private practice, working with those who are suicidal or experiencing suicidal distress, but also in research and you know, a whole range of training and education, how pivotal it is to have those who actually know how it feels, the impacts on them, whether they're someone who cares or supports someone in suicidal distress, whether they've been impacted by the loss of someone themselves to suicide or exposed to suicide. There's many different levels of that, or whether themselves are suicidal. So all of those experiences have taught me so much. And I didn't have my own lived experience. And so I was very much drawn to appreciate that we need to know more around those experiences, and, you know, not be scared of them, because there was tended to be, particularly back then, still this major stigma. And I thought, as a young person back then, younger person, with the young person strategy, we have to do stuff about this. And so I basically went for the position, got the position. I was a senior researcher at AISRAP at Griffith, where I've now been there for just coming up to 26 years. And yeah, and I've just completely loved and adored everything that I do. I've been very fortunate to have a casual clinical practice. I'm a clinical psychologist. Supervision, I run supervisor workshops as well. But the key part of my academic role has been teaching and education, primarily over the years, developing the Masters in Suicidology, grad cert in Suicidology with Professor Diego De Leo, Emeritus Professor. He left in 2015, but was there since 97, setting up a global kind of international centre. We're a World Health Organization as well. And then kind of morphed into doing a lot more research from a, I guess, clinical suicidology perspective, which is where I did my PhD and where my passion. I was really fortunate to have everything that I wanted to focus on come at a point in my career as well, where I had resources and better competency and knowledge to really investigate the phenomenon that I wanted to. And so I can balance, and I was able to integrate and balance the research, my practice, so real world stuff, with also education and training. So it's like this circular or reciprocal, if you like, relationship between those three key domains. So it's always complex and changing. I think so that's kind of where I've come from and where I am today. Yeah.
How has the research into suicidology changed over the years? And I ask that because it seems like today there is a lot more public awareness, that although the taboo is still quite high and strong, and there's still, at least from the community, some concern about talking about suicidality. We've got campaigns like Are You OK? Beyond Blue, that talks about depression and suicidality and the like. How have you seen this space change over the years?
Yeah, really good question. So, I mean, I think it's changed on a number of levels. So if we start with the research, certainly I've seen a couple of major changes in research. The first is the volume of research, and I perhaps can't not then talk about what I think is probably related to that, and that is that the stigma has been lifting. We're still nowhere near good enough with regards to reducing stigma around suicide, especially the view and perception that suicide is a mental illness, which we now know is of course not correct, and it's a behaviour. Nevertheless, there's still an association there. But with the reduced stigma, I think there has been an increase in volume and body of research. There's a lot more openness to, and from an ethical human research ethics committee perspective, a lot more openness to address some of the challenges that were traditionally seen as being too hard, unsafe, unethical, too scary, litigation elements, blah, blah, blah. So I think I've seen quite a bit of change around acceptance of suicide, the phenomenon, and the need to research it. It's been resourced way more when we moved at a national level from youth suicide prevention strategy to the national whole of lifespan strategy. So that happened in 2001, around there, don't even know, somewhere around there. So in acknowledgement of the fact that the cohort most at risk was no longer the young people, which peaked in 1997, but moved into being, the 34 to 44 age group. And so following that trend, the allocation of resources included research. So we saw this introduction of different research funds that specifically address suicide, still nowhere near enough, but enough to acknowledge the value and importance of research to underpin what in the 80s came about as evidence-based practice and client-centred care, etc. So there was this real emphasis on trying to move with this landscape from just doing kind of what we used to call rats and stats research or statistical-based kind of lab work, behaviourist focused, etc., which still has a place, of course, in different domains, but in this very human, complex, multifaceted causation phenomenon, there's definitely been this shift to acknowledging how tricky that is to research without resources. We've gone through many phases, different governments. I mean, probably it's one of the things that increasingly has received bipartisan support. So when you're looking at funding a high level kind of lens around what's being funded from a research perspective, it's probably one of the domains that it's kind of capturing both agendas, or all agendas, I should say, which is obviously important. Never enough, of course. We always used to talk about at least 10%, if not up to 30% of any funded research project should engage evaluation, and not just does it work, but a lot more today around from the very inception of a research project right through to the end, process evaluation, impact evaluation. And I mean, one of the, that related to that change that I've seen over time is also increased awareness in the research community and the sector as well, that we do need to know what works and how to better do what we do and how to not waste funds. Why would we keep funding something that wasn't working? And hand in hand with that leads me to the second big change at the higher sort of level is that real engagement of lived experience and acknowledgement of co-design processes, co-production. And so, yeah, mostly that sort of focus on consumer-based care and involvement in co-design had occurred several years ago, of course, in mental health, but not as seriously or as focused or even labelled and acknowledged in suicide or suicide prevention. So there's two sectors going on in our that overlap, complementary, and I don't like to kind of take a stance on whether one's better than the other or one's, you know, in terms of where we should address suicide, because I guess suicide has a need for upstream prevention, whereas a lot of where mental health and wellbeing sits. And that should be a big focus of where we put funds and conduct research, right through to kind of the pointier end where people's individual trajectories haven't been interrupted. Or, yeah, so there's a number of that lived experience focus I should come back to is increasingly valued, which is an awesome thing. I think it comes as well with being inclusive generally in society today, more inclusive, I should say, acknowledging more diversity and culture and all the things that would never have been spoken about, I think, or acknowledged as much, I could say, in our sector, you know, a couple of decades ago. And it was always clinicians versus consumers or clients or however you like to say it. And we clinicians have all the power, and so that at a service level or a practice level has been the other massive shift of evolution that I've watched. You know, since antiquity, of course, we've had suicide, but it's the one thing that the behaviour's been there, but the way that we've responded and interpreted suicide has changed, and it's changed a lot because of listening to the voice of lived experience. And yeah, that has become a real meaningful part of clinicians' acceptance, or slowly acceptance, I should say, not globally, but slowly accepting that we don't have the power, the expertise, the knowledge. We have to sit there and listen to the experts who are our people in front of us, who don't need to be controlled. We don't need to be focused on how to treat them, but collaboratively trying to understand and compassionately, and all the wonderful principles that we're taught about in our first year about humanistic Carl sort of philosophy. This is the stuff that is central to, I think, and that I've observed shifting, that is central to, supporting someone and keeping someone safe and empowering them really to find ways to feel confident that they can cope with adversity, and that's a very micro level. Of course, at the macro level, there's a lot of change that people really are powerless to address around economics, housing, and we as a sector and as a community, as a government, we need to respond better there. We need to provide, this is the upstream stuff I'm talking about, provide psychologically healthy and safe workplaces, look out for each other, ensure that people have access to good healthcare, housing, etc., and empower people with educational opportunities. All the real significant social and social justice, human kind of rights kind of domains, require a different high level response integrated with our clinical and non-clinical kind of responses to people.
Can I just pick up on a couple of items before we maybe move into the psychosocial factors that can be considered? I just want to say it's very encouraging, firstly, that you've seen, a bipartisan approach towards research and looking at it more on that federal side of how do we try and understand suicidality, not only from a program perspective, but from a lived experience perspective, and asking the people, who might traditionally not have a voice to get their input. So that's really encouraging and beautiful to hear, particularly from someone who's spent so much time in this space. So that's fantastic. And I also like this idea of that 10 to 30% of funding looking at not only just outcomes, but rather reviewing the process and trying to really understand how did this land, how was it experienced by consumers, clients, whatever we call that, because I think that's a missed opportunity. We can often just go out and say, what are the numbers, and then that's kind of that versus, I suppose what goes into the third item that I wanted to touch on is wanting to potentially look at the process base, not the treatment base. And I say that to try and clarify a little bit more. You mentioned that there's almost been a bit of a change in the culture or in the tide of moving away from suicidality being a disorder, a disease, a problem that should be treated, should be fixed, to more of a support basis of a process of working with someone about how do we keep them safe, what's it like to live with suicidal thoughts, compulsions, feelings, desires, how hard it is to live with pain and that level of discomfort, and working alongside in a collaborative way rather than having power from a professional client dynamic being together. So that's really something that I sort of reflect on as you were talking, that some real strides, some real steps have occurred over a period of time. It's really encouraging, and I think that's probably something that I feel I've potentially experienced in my shorter career. There is more openness to talking about suicidality and a lot of normalizing that's occurring. And I know I encourage a lot of clinicians to be a lot more curious when doing a quote unquote or air quotes risk assessments. We're not here to check boxes, and because it also infers there's something wrong with the experience of having suicidal thoughts, but really being curious and trying to understand. I think there's a process that goes along with how we might support people, going through this tough time. So maybe that lends itself to some of the psychosocial factors. Have they consistently been somewhat the same over the years? Are you seeing any trends? What's the research sort of pointing to?
Yeah, and so and Nesh, just before I do talk about that, I was going to just pick up on your point about, yes, there's been these shifts in quite positive ways, right? And these are important shifts that we acknowledge. I also just want to slip in there, because it's so important as well, that there's still a huge amount at the clinical level in our health service systems as well. Whilst there's good stuff happening, there's still stuff that we need to be aware of that's not so good, and perhaps derived from systems that are not that positive in terms of being compassionate with care, and still having very negative attitudes around those presenting with suicidality. Coercive control is becoming quite a bit of a thing it's always been a thing, but getting a bit more media coverage. So unfortunately, there still are very tragic and sad stories about how people are treated, which at the root of it, my belief or understanding, slow knowledge gains around this space, but have a lot to do with the system within which people are treated, from being low resource to having hasty kind of practice, burnt out staff, and even leadership, of course, is a really important thing as well, to being able to identify these adversities in the system, and be adaptive in leadership, being able to respond adaptively to such complexities. And we're probably not doing hugely well across the whole board with respect to that. So I just want to say, yeah, so there's great shifts in
could I pick up on one of those items? My apologies for jumping in. Obviously, in the spirit of being curious and not being negative, but rather, these are learning opportunities. And I think that sometimes we need to point to something a bit more directly, and it's not from a critical point of view, but an observer point of view. What have you observed have been places where improvements could be made? And I know that you mentioned things like, low resources. It's kind of like a bit of a general umbrella, or hasty practice is a general umbrella. Could I gently invite you to maybe be a bit more direct about, opportunities that could be improved on? And as I say, this isn't a critique, pointing a finger exercise, but rather saying, what have you seen as a researcher that we can, opportunities to advance on?
Look, definitely. I don't know if training is even the right. It's definitely a system-based change. It's a legislative change. I think we need to focus on human rights. We need to focus on, if it was for the people in the system operating these services, particularly, for example, in inpatient wards, triage systems, this sort of thing, where suicidality is still being predominantly treated, by the way, as opposed to resourcing up the community to respond to a behaviour that will most likely more prevent longer-term representations, etc. I mean, we have data and research evidencing that psychiatric patients, those who have gone into hospital, once they're discharged, they're at 150 times greater risk of the community in that first month post-discharge. So of re-attempting or dying by suicide. So we know that something's not right in that system. And still today, there are stories, many of them, where people are succumbed to, treated like straight away, put into either straitjackets or put into the wards, or they're treated badly, just not, they might be wound up, they might be agitated, they might even present with, the comorbid symptoms of mental illness. So it could be with some sort of symptoms. I'm not going to go into diagnoses, but that do take away their own control around their behaviour, their experiences, that sort of thing. So the reactions that we have at these times, sometimes they do have to be contained, but should never remove someone's rights to be able to, there'll be some instances where they can't potentially have cognitive capacity, but mostly people, even if they're a little bit upset, frustrated, I've seen it because I've waited for hours in my practice many years ago, or at least 7 or 8 years ago, in emergency departments with my clients, when until I've said I'm a psychologist, I'm here advocating with supporting this person, the kind of interactions, the engagement wasn't even a human one. So it's, I think, whether training address, I doubt. I think it could be helpful, but an adjunct to a more of whole of system response to just understanding that the more we try to control people, and labeling is one of them with diagnoses, although there can be, we have to ask the patient or the client themselves. For some, having an understanding via a diagnosis can be extremely important, invaluable, in fact, on many, many levels, not just from getting access to healthcare, which is unfortunately a sad thing, but that's the way to get it, or because it really does help externalize or explain what is happening for the person for whatever causation. So I think that, yeah, there's a lot of change that can happen around how we understand people experiencing the desire to want to die, what stops them from wanting to live anymore. And I don't think how we treat people from waiting room triaging right through to inpatient is always, there's some really good examples of compassionate care, but not always conducive to people feeling human. So when I do training, I often speak with my peers in a way that helps them to understand, because science has shown our attitudes change the closer experiences are to ourselves, but try to understand if that was you, your son or daughter, your partner, your parent, your best friend, how would you want them to be treated? Like if you were trying to get help for someone that you cared and loved about, what is the ideal? The ideal should be your gold standard. So I've never heard anyone say that they want them to be treated badly, abused, have their rights taken off them, and but commonly we hear they want to have a compassionate interaction. They want to have the opportunity to consent to what's happening. They want to be informed. They want information, and they want to be heard. They just want to be heard. And even if you don't have answers and solutions, the amount of even qualitative studies emerging around ED and other mental health settings, etc., where people are actually asked what works, they say, I just want to be heard. And to have an interaction that allows them to feel validated, not judged, and, not belittled or disempowered. That in itself, and we don't know how to measure this, of course, can be the very factor that facilitates not just de-escalation and experiencing calm and safe, but something that can actually prevent, as a treatment modality even, so representation, can potentially interrupt what might be like the ensuing crisis or escalation. Of course, these momentary things are very difficult to research and capture, unlike things that are more static. We always measure, gender or homelessness or unemployment or all these other things that we refer to as risk factors, but we don't actually do very well at measuring the more momentary elements. Stuff, because we know that suicide's fluctuating is hard to grasp. But to come back to the point, yeah, I really think, within systems there's great capacity to let people who've been there and responses, etc., to that. And there's a lot of focus on some of these issues as well. So yeah, that's kind of the space that I think we could and we should address to improve care.
Is there research that has tried to understand that more personalized care, if I can use that as a language, and it's probably not the right language, but in terms of meeting the client. I mean, I like that language and I use that in my clinic all the time. I talk about each of our clients is like a family member. How do we want our sister, our brother to meet us, to experience us? And I've had friends and family come through our clinic, and I never tell any of our clinicians who they are, because I'm very confident in the service that we provide, and it means that we're treating everyone with the utmost care. And obviously, it's a ethos that I try and bring about, and I'm very passionate about. But is there research that's been able to tap into how that factor might moderate, suicidality, or as you mentioned, potentially reduce that 150%, increase rate post psychiatric care sort of release?
Yeah, excellent question. And in different ways it's been examined, mostly using combinations of both quantitative and qualitative research, so the mixed method sort of approach, but certainly also just pure qualitative research. And these are the means of being able to obtain, even though there's a lot of idiosyncratic information, you still can do really good analyses and getting good thematic or common elements that in response to the questions being asked. But I would have to, the first thing that comes to mind is psychosocial assessment and care conducted for those experiencing suicidality, particularly studies that have been done in the UK, to really take a hard look and examination around the impacts of doing psychosocial needs-based assessments for those presenting with suicidality versus treatment or assessment as usual. What you're referring to earlier is the checklist kind of, low, medium, high, which is completely unhelpful. And traditionally no longer actually is best practice care. So you wouldn't, for example, suggest ever that doing such an assessment. There are some hospital protocols today locally and elsewhere that still do tend to rely on these protocols which categorise risk outcomes. We know that they don't work, and we know that studies have shown that use that approach, that there's a very high majority of those who are given high risk that will never go on to die by suicide. Those who get low to moderate usually are those who will go on, at least 40% will go on to attempt or take their life by suicide. So, and there's a range of studies across many different countries that support that data or that outcome. Usually we allocate high resources to those who get high risk. So there's a double whammy, fallibility in this approach anyway. But what I was going to say therefore, so we don't any longer refer to doing that sort of thing with respect, or process, if you like, for assessment. What we refer to as psychosocial needs-based assessment. In the UK, the NICE guidelines, National Institute for a Centre of Excellence for Care or whatever, does cover 2022 as the most updated version on the NICE guidelines, NICE. There's an editorial on it in the British Journal of Psychiatry, actually, that nicely synthesised the updates that have occurred since 2011 when they first were released. From the UK, we tend to follow those best practice standards, which include doing a psychosocial assessment and based on the research that I'll talk about in a sec. But here we have RANZIP guidelines, so the Royal Australian New Zealand Psychiatry Association have also adopted the NICE and refer to the NICE guidelines from the UK for their best practice standards, and also present research that demonstrates how important it is to do a psychosocial needs-based assessment. I guess the question following from that is, what is that, before we get to the impacts of it and does it work? But so psychosocial needs-based assessments involve understanding the needs of the person. So what are the contributing factors, because they're different for every single person, that they say and tell us makes them want to die? So what are the things that contribute to them having no reasons to want to live, quality of life low, unbearable psychiatric or psychological pain, as Schneider referred to as psychache. So a number of different experiences, what leads you to that? Usually you do hear, and we do know that these are also risk factors, traditionally studied as risk factors in literature. Homelessness, financial problems, separation, divorce, financial problems, did I say that? Drug and alcohol problems, sometimes other comorbid or things that are occurring simultaneously, mental illnesses that make it tricky. And usually it's not even the mental illness itself, it's usually what's associated or what comes with that, from stigma to being unemployed, to being ostracized, to feeling alienated, even a self-fulfilling prophecy around that these things are going to happen. So internalizing that stigma that exists. So yeah, there's those sorts of things that we want to understand when we ask a person about their needs. Essential, together with a psychosocial, what it incorporates, psychosocial needs exploration, is understanding the suicidal state. And we want to be really careful when we say, and I've heard this multiple times in the last several years, that we don't believe in and we're not to do a risk assessment, right? It's really more a play on words, and we need to understand conceptually what we're saying. So we don't want to throw the baby out with the bathwater. We're not saying that you don't do any assessments at all. And people who are not working at the very pointiest end, and when I say pointiest end, I don't even like that term, but I mean when people are experiencing acute distress and they're in a space very near wanting to implement, going from ideation to action, implement a plan, the level of response, yes, it can be well dealt with a non-clinical, safe holding response, but there's also some level of intervention that needs to occur usually as well, that we know requires real deep understanding of that person's suicidal state. What's going through their minds? What are the things that occur for them that make them, or that lead them to immediately wanting to die? What are how frequently do their thoughts happen? What sort of thoughts do they have? In what context, what situations, what context? So there's a whole heap of information we can only gather from hearing their story, from really understanding how they experience life in their cultural, environmental space. It's like an ecological, if you like, understanding of that person in their individual, interpersonal, familial, community setting. When we can understand that understanding can come through investigation or exploration, if you like, and hearing their story around what brings them to the point of wanting to die. So we explore their ideation, their thoughts. We explore the things that bring them down. So people, if they're in front of you and they're living, they have to have come down at some point from that highest point of wanting to die. What is it? Let's look at as well. What are all those factors or experiences that bring them back to the point of wanting to live, even if it's temporary? A suicidal state, in fact, also involves three domains: looking at the past, what's happened for them, have they ever been there in the past, the present, and also helping, helping them to keep us aware of what their immediate future is as well, that foreseeability in the very, very short term. We know no one can predict suicide. We know even the person themselves, they even get really peeved when we say, oh, you know, and this is a traditional question we used to ask in the past, but do you think you're going to go kill yourself after you leave this? You know, leave me or go from here. You know, those sorts of assessment questions, which are not helpful at all. So these are the sorts of things that we can only understand, not through a checklist approach. So it's important to understand that a psychosocial needs-based assessment, according to the guidelines, isn't just what are the psychosocial factors. It's about the whole experience of suicidality, taking account of the suicidal state, plus the factors that they say are their unmet needs or things that they'd like to be addressed that contribute to them wanting to die, and understanding those things that keep them alive. And getting the person to prioritize all of that for us and you tell us what you reckon is going to work best. We'll walk with you and we'll take over driving or doing the driving, you do the navigation and vice versa when you can and can't, or are less or more likely to feel that you can, till we get to a point of, you know, improving the quality of life that you're having, where we can do that together. But mostly, you know, when we do get clinicians working at these really intense parts of the journey for people when they're experiencing suicidality, they've usually gone through a point of where safety alone, trying to keep someone safe is great, right? But it's also not always the only part of being able to support someone through their darkest points looking forward as well. So and that's kind of where my research starts, is psychosocial needs-based assessment, which is why I'm pretty passionate about it. So better stop talking.
It's very refreshing. I know quite a number of years ago now, I spoke with Kirk Strozel at the time, as one of the founders of the acceptance and commitment therapy model. And we were specifically talking about suicidality and understanding and supporting around that. And he echoed very similar things in terms of not going through a checklist, but rather being incredibly curious. And what's interesting around that is, if you can be curious and become a reasonable historian, as an example, or take interest in the current or what that immediate next future might look like, many of those tick boxes, the check boxes of the risk assessment, actually come about. They actually come out of inquiry and looking, rather than having to be specifically asked. And the information that is then provided by a client not only informs potentially what that next step might look like for the client, which they get to internalize rather than being told, or that power dynamic is different, but it also tells them that I'm here and I care and I'm interested. Someone is here to hold you, so to speak, or hold the pain with you. And so I'm hearing that psychosocial needs-based assessment is very much in line with that, and hence why the checkbox system is not thrown out. It's just how we do that. But I suppose the other side, if I speak about the scared clinician, or the fear that comes in the room, is, but I need to check the boxes, because if something were to happen, Jacinta, then what would happen to me? Would I be questioned because I didn't ask the checkbox system? Am I the one that's going to be queried? What does that mean about my registration? Do I have a legal responsibility to make sure the client leaves with a safety plan, etc.? And I think in the space of fear, or low confidence, many clinicians might lean back into, give me my safety plan so I can tick those boxes. I put that in the clinical notes, and therefore, fear averted. And I think that might be a forcing function, and maybe it lends itself into the next question of, you mentioned that there are some legal items that might also play into this, or maybe we can talk about what are we expecting of clinicians in these scenarios that we can feel comfortable about, ensuring that I can hang my hat on this and say this actually is best practice. Maybe a safety plan wasn't formed in that particular session, but I was still doing quote unquote therapy. I was providing a service. I was still meeting the client's needs. But we didn't, sign a contract or do some, old school, that you won't do something terrible between now and next session. But I still did make a bit of an assessment. I did check in somewhat around a immediacy around a plan, or whether there was you know, a need to be a little bit more concerned about whether something's going to occur, or there's a timeline, you know, that I've checked some items, or can I say there's actually future planning? Like, for example, we're going to make another appointment. We're going to examine this a bit further next session. I want to know more about what some of these thoughts or frequency of thoughts or the dynamic of the thought or the context, how that impacts and so on, that there's future planning going on that I can kind of say, yeah, I think I'm still meeting the client's need.
Mm-hmm. Yeah, I mean, okay, so I'm going to answer in a roundabout way. So, and I'm going to, it's very important to connect it back to the part I missed to respond to previously on the research, right? The evidence we have for psychosocial assessment. So I think we always got to come back to the research, but and that research includes the voice of lived experience, collective voice of lived experience in a lot of these studies. So I was referring to the NICE guidelines and how that informs best practice and where we need to be in terms of our standard, gold standard, if you like. The research that has been conducted on implementation of that versus treatment as usual has demonstrated reduced repeat presentations by people, and these are all in hospital-based settings, like across 16 or more hospitals, UK, Ireland, etc. But also, and particularly for those who do have psychiatric diagnoses as well, that's a bit more significance happening there. But secondly, increased engagement with services and follow-up care and desire and motivation to want to be helped and to engage in that treatment or that sort of support response because they feel more empowered and more control, etc., etc. And there's papers by Leah Quinn-Livin and Nav Kapoor, Keith Horton, Alexandra Pittman around a whole range of, and their co-authors around a whole range of studies that have been done on that to provide evidence for that approach versus the checklist approach. Similarly, and way more powerfully, because there's I think about 8 now randomized controlled trial studies on David Jobs's from the US, Washington DC's collaborative assessment for the management of suicidality. So Dave has done quite a bit of work. I'm a fond friend and colleague of his around implementation of his model, which also includes psychosocial assessment focus, but in addition has a 6 to 12 session or 8 to 12 session, depending on presentation, etc., and experiences, support response / management plan, which is a leading suicide-specific evidence-based approach to responding to suicidality. And there's others. I mean, there's Marshall Lanahan's, late Marshall Lanahan's dialectical behaviour treatment therapy for those who do have motor regulation and other presentations that meet the criteria for her treatment that have demonstrated equally reductions in suicidal ideation, which Dave's has, over the long term with follow-ups and in RCT model designs. We haven't got yet to suicide in the CAMS, Collaborative Assessment Management Suicidality response, but there's promising results coming out. And he's also done it across many settings. So his model was across many settings, from hospital to outpatient to community, etc., military, etc. So there is definitely good evidence to show how psychosocial assessment in a systematic way that's collaborative and person-centered, together with, in CAM's approach style, at least as an example, together with some sort of person-centered response that's systematic, we can see positive results. But what is the thing, in getting to your question, that is I guess the the central component of this work that prevents clinicians and non-clinicians, I guess, in the workforce, increasingly non-clinicians today, prevents them from really engaging and not screening people out. That what is the central elements that, as you said, drives increasing fear and anxieties, etc. And I think it's just a lack of knowledge and myths surrounding what is what I guess what is going to bring about litigation, or as you said, APRA or whatever other registration bodies, complaints and notifications, or however you like to describe it. So I do believe that we haven't been educated enough around not just the phenomenon and how important it is to hear and work more closely with the expert so that we do the best, most commensurate care, which I'll get to. But it's also the fact that we have these fears that if a client dies by suicide, and sadly, when you do work in this space, there will be clients that die by suicide.
Yes.
You can do some cases, you can do all that you possibly can. And my life is dedicated to that. And I've lost a client to suicide I was working with for 7 years, and it is surrounded by many other health professionals. And it is a sad, tragic occurrence. And I think we fear having that experience. We fear death. We don't talk about it enough. We're not educated enough about how to best respond, how to continue to practice when we don't have preparedness. We haven't been taught about how impacts on us of this work can be managed, can be understood and become useful and positive moving forward in terms of career. So I think there's a lot of stuff there. Our supervisors have the same sort of experiences. So how do we expect them to supervise? And I'm talking generally. Of course, there's many who head on will approach and respond and support suicide-based care, suicide-specific care with people. If we want to understand our anxieties and fears, we just have to go back to the 80s, 90s, when we did work with young people, and there was a strategy and actions for responding to young people in suicidal distress, mostly in emergency departments. And these were things like no suicide contracts. Right? We just have to go back to then, when we were so anxious as a workforce that we'd lose someone to suicide, that we just said, quickly, sign this. Now, I just need to know, will you go on to kill yourself? Just tell me that. Can you just sign here, blah, blah. So it's more of, and I think majority of people are well aware of this now, that it was more a vehicle to protect us, to make us go, walk home and finish our shift and feel okay. It certainly has never had any legal standing, never ever can facilitate or be used as a legal component of care, because of the fact that it doesn't work. And in fact, it does everything to the contrary of what we're trying to achieve in best practice today. It's disempowering, it's punitive, it's marginalizing, and it's a whole range of things. But the worst thing is that it's helping us once again and not the person. And so we then have once again more control and power. So I guess one of the things that needs changing, and the late Barbara Stanley and Brown in their safety planning model have tried to address this, is, safety, keeping someone safe is about, the only way to do that and to be conducive to them wanting to live is to engage them wholeheartedly in that process, not punitively, advice giving, why don't you do this? This works. The research says this works, use this. Overly, or what we call prematurely injecting hope, or prematurely moving into an intervention space, including safety planning, before we've done a deep dive into merging, as Israel Orbach would say, merging with the suicidal wish. We need to be able to sit with that, explore and understand the suicidal state and how painful that is before the person gives us permission, not necessarily verbally, but to walk with them into providing safety and some sort of, intervention. And safety planning, if it's done properly, isn't a checklist approach. It isn't walking away with a little card to just make us once again feel better, like when we used to do like no harm contracts. but it is an actual standalone intervention. In my research, and Professor Diego De Leo and I in 2015 first developed the systematic tailored assessment for responding to suicidality protocol. It is a psychosocial needs-based assessment protocol. It's undergone many changes to move with lived experience, to move with the shift to giving control to the client, and to keeping them safe. And in this latest 2024 version, which was informed by lived experience directly, and there's research papers on it, it is based, the safety planning part of it is based on providing a commensurate response to what we've gathered around their needs. So duty of care today, and I know a lot of clients, and we should ask their permission around how they experience these words, but duty of care is about how we can best practice a compassionate and safe response for our person, as opposed to ticking our boxes to keep our butts safe and secure legally. And that's a big shift and a big difference. And in our semi-structured protocol interview, it's very much a big picture. We want to get to here in keeping you safe, yes, and then planning forward how we're going to together work to improve your quality of life. But that may involve a brokerage model where, to address all your needs, we need to engage people that you suggest that you want to be involved with your care, from financial to trauma to whatever it might be. But the assessment process itself, we believe psychosocial assessment is one that cannot not have some sort of safety care plan element to it. So yes, Brown and Stanley's is an intervention that's standalone, but it's also a part of, and should be a part of, commensurate care when we have information. If it's going to work, and we don't just keep coming back, see representations, if we want something to work and it's an evolutionary thing, it needs to be readdressed as the person grows and develops strength and confidence in how they cope and how they've best interrupted an escalation of, in their own little trajectory from ideation to action, etc. That may need modification as they get better at dealing with one thing. They might want to focus on keeping safe in other ways down the track. Different people, So I think all of that, and the way our protocol is delivered in terms of training around its administration, is it all comes back to competencies, and the competencies, best practice competencies today. My colleague and dear friend, Professor Rob Kramer, and others from the US and the UK, together we have just published last year an article on core competencies for suicide assessment that show a tiered-based response, if you like, for the workforce, from the types of competencies necessary to be a gatekeeper, where I know a lot of people don't, we're moving a little bit from that terminology, gatekeeper, but someone who's a life keeper, if you like, but someone who kind of engages. They can identify signs. They could be teachers, they could be, shopkeepers, hairdressers, family members.
An impactful supporter. Yeah.
Impactful supporter, yeah. Well, they have a really important role, but the competencies they need to do that role are going to be different to someone who, for example, is having to work at an end where someone's literally wanting to take their life, implement their plan. They're potentially in a space where they've been there for a while, they can't get out of it. They need more than to kind of identify, refer, and engage, which is an extremely important role, right? Absolutely important. And it's probably where we need to put a huge amount of resources there. But where that isn't enough for some people, there's that paper, that article goes on to talk about, well, there's other competencies that are required, one of which is understanding your duty of care, understanding from a lens that isn't a protect me lens.
Yeah.
But it accounts for what does duty of care mean for us? Like, our patients and clients deserve, like any of our family members, ourselves, whatever, would want as well, to to be cared for in a way that is the golden standard of NICE guidelines, for example.
What's so interesting here, Jacinta, is the moment we talk about suicidality, the fear response comes up, and so there's that immediate act of what do I do? I'm afraid. I need a checkbox. I need to follow something, and that means that we deviate from our regular practice. What's interesting is if we don't call it suicidality and we call it emotional distress, we would lean in naturally as clinicians. We would take an interest in understanding the client's psychosocial needs, whether it's, family, social supports, finances, what challenges they have at work, where there might be a relationship breakdown, just all context, the volume of work they have that they feel swamped with, so on and so forth. And then we'd look at how we can support, step by step, those circumstances or the situation, or even the state that can sometimes arise in its most acute periods, which we would then go out and respond appropriately to with regards to balancing that compassion side, and also keeping the client safe in the space of suicidality, which is so interesting because it's the moment we change the term from obsessive compulsive traits, experiences, to suicidality, we shift. We're like, oh, what do I do here? As though the human has changed. And in actual fact, more of that leaning in, and it doesn't mean that we don't look at appropriate care, but we do that as clinicians all the time. It's just that I think we can be unsettled. And so I love the way that you haven't used terminology in terms of diagnoses and categories. It's very humanistic, and it talks about an experience, which I think is so refreshing, it's humanistic, which I think is so important. It speaks to the person, and I'm not suggesting that labels aren't of value for some, but I think describing what's under the label is actually even more powerful than the label itself, because it's validating and it explains it more thoroughly. Can you maybe talk us a little bit through, I know that time's catching up to us, but what's the training that's been developed? Where can listeners find out more about the training, the competencies, the semi-structured, interviews, if they want to follow up on this, whether it's clinicians or whether it's, people who are interested, loved ones that are, have family members that they're concerned about. Where can we find out more to if it's piqued an interest, finding out more about these best practice, and I think reinforcing this conversation is helpful in other ways, whether there's a website, books, obviously papers, as you mentioned. Where could we find out more?
Well, if I start biased, if I start right at the top with regards to psychosocial needs-based assessment and training, if we're talking about, particularly the area that I've been involved in,
Yes.
Currently I believe it's the only psychosocial needs-based systematic interview protocol in Australia at the moment. In the world, there's a few, including Dave Jobs's and a couple of others. And so the acronym is STARS protocol, STARS protocol training. If you were to type that into the web, you'll come up with the Griffith University webpage, where it talks about all the conceptual elements and competencies that are taught in the training. Generally, that's available for those who work with those or are in contact with those in suicidal distress.
Sure.
It doesn't have to be a clinician. We have people who are lawyers, we've had accountants, we've had clergy, the peer workforce, people with lived experience that their job is to support those in suicidal distress. So it's quite a broad mental health and non-mental health professional workforce that engage in that training. Certainly, if you have a look at the article that I talked about before that came out last year, it's called Updated Suicide Prevention Core Competencies for Mental Health Professionals, Implications for Training, Research and Practice. And that article lists all examples of all different types of training: gatekeeper training, which is at the kind of minimal level, then medium-based training, which is where STARS comes in, STARS protocol training and others. And then, of course, at the highest end would be those that involve treatment as well. So David Jobs's Collaborative Assessment Management of Suicidality. So there's all references for those in that particular article. They can also just Google those particular interventions as well. There's a great gatekeeper training in Australia from Living Works, Assist training, Safe Talk, etc. There's Mental Health First Aid Australia training, which includes also suicide gatekeeper training. These organisations are kind of moving a little bit away from saying the word gatekeeper. There's also Roses in the Ocean in Brisbane, Queensland, but also they're all around Australia. They provide lived experience, developed, designed and evaluated gatekeepers training. They call it life keeper training. Touch Points is their package at the moment. I've been engaged in evaluating lots of different training, including all of the people or organisations that I referred to. So I can say that they will definitely have impacts, positive impacts. No trainings really yet. There's a couple of randomised control trial trainings, but few have actually looked at longer term impacts of the training, including mine, in terms of retaining knowledge, skills, etc., in the very long term, but as well as having impacts on clients. So it's more about increasing confidence, skills, attitudes, etc., to enable us to do a better job, including from gatekeepers right through to clinicians. And I would suggest that, I guess one of the biggest things is you can't go wrong. You just can't go wrong if you are being a human, connecting with and non-judgmentally and compassionately supporting another human, right? So this is why a lot of gatekeeper trainings, you can't go wrong. You don't need to know what to say that's correct. So long as you can, you might remember one or two or three things from that training, but that's usually what is most helpful in that moment for a person. If it's about validating them, supporting them, the fact that you want to do the training, the fact that you have an interest in supporting people is a guaranteed compassionate response in itself. Of course, when you get to a point where the person needs a bit more help, you need a bit of extra resource. So, not always those trainings give you information about local resources and where you can refer and how you can actually pass the baton in a nice, warm way so the person's not left, unsafely and that sort of thing. So I'd say be resourceful wherever you're working. No resources if you're virtual, no resources where the clients that you see that you're meeting with are based. Make sure you tap into people's workplaces if they're employed, because workplace supports are really important. And the other thing I'd say is when you do get to, if you're clinicians and you're to not be afraid about, please don't screen people out and turn them away, because that could be a life that could have been saved. You can reach out to support with supervisors. You can consult. If you're ever uncertain, a person who wants to live, usually if they're sitting in front of you, will wait with you to get extra consultation and support. It seems like really logical, but we don't think of it. Our anxiety usually takes over and results in lots of suboptimal responses, either going, oh, you'll be right, you've got so much to live for, or I need to send you to hospital. So neither of those are helpful responses. So just tap into resources. Obviously, some of the trainings I've mentioned might be helpful. But always reach out for mentoring or supervision or peer support. Yeah.
Look, I think training cannot be underestimated. I know that probably close to 20 years ago now, I did an assist training program, and I still use the two primary things that I took from it, and still think the value of it is immense. One is not shying away from asking very clear questions. So
Yes.
instead of having, I'm having dark thoughts, and kind of shying away from it, just asking very openly, are you talking about having thoughts of suicide, killing yourself? Number one, and they made sure that retention was strong because they made all of us say it out aloud, because it was something that was taboo and scary and so on. And so, I would imagine they get a big tick in the box if we were to, review their training and the retention side of what we took away from it. The number two was working with ambivalence, validating the one side of, I understand there's a part of you that does want to die, that wants all this pain to end, etc. And I'm hearing also that there is a part of you that still wants to live, and what are those parts? And so just those two elements, training, and extending on the work from that. And there's so much you've listed, so much. I can only encourage any of the listeners to continue to look for that, because I know that many of the younger clinicians can be quite overwhelmed, and they're looking for guidance, and there tends to be this push towards give me the checklist as my guidance rather than a process, a way of working. And so I've often, sent my clinician psychologist to some of that work that I spoke to about Strozel's work. And now I've got some, I will be using this podcast as well. Appreciate that. Has this entered any of the universities yet? I'm assuming there has to be a slow progression because we're talking about evidence-based, and there being RCTs that are being conducted, that over time we start to lean into that and kind of say, hey, graduates, or those to be about to, this is part of our program. Any word on that?
Oh, what a great question to end on, Nesh. So right now, my colleagues and I from Monash are working on a study to look at suicide prevention curriculum, apart from postgraduate programs that we have at university that are more broad and focused on contemporary practice, and because they're university degrees, like qualifications, but actual training programs or educational foci on actual development of these specifically suicide-specific competencies in and of itself. We're working on some research grants and also have already done quite a bit of work of what are the needs of both undergrad and postgrad across multiple disciplines, but specifically psychology, because we're all psychologists, but we're broadening it out across because it's a multidisciplinary workforce, right? What are the needs, and not just of the students and university students, but the workforce, where the interface is going to occur when they're sent out with their qualifications, but also the university curriculum advisories and a whole range of things, because currently, at least for psychology, but other professions, their requirements for accreditation are already very jam-packed. We need to shift that and make space for this important stuff. So we're working on that, because many universities might have a little guest lecture here or there or something. And I wouldn't say it's tokenistic. I'd just say it's an attempt to try to cover something, but it's nowhere near enough. So we've never treated suicide assessment, response treatment, support in the way that it should be. We've never brought in co-design and lived experience to tell us what they want us to learn as a workforce. That's sort of changing now. We're trying to do that. And I'm also working with the International Association for Suicide Prevention on an interest group, which has 32 countries involved in a study I'm co-chairing and co-leading with Sweden, which is looking at getting a baseline of universities across all these countries. What curriculum do they have, if any, and where do we need to build curriculum? So it's early stages, but it's exciting space, because it seems really silly that we don't have it in any as a proper structured course, right? And it follows and makes sense as to why it's not there, because it follows that is there a requirement in terms of a competency for registration bodies across these disciplines either. that says you must have a core competency. So yeah, so we're working to sort of see if we can change that. I'd love that to be my legacy, or our legacy as a group of researchers and educators when we leave, and clinicians when we leave post-retirement sort of space.
Jacinta, I wish you all the best in that endeavour, and hope it comes well before retirement. And you know, I genuinely want to express my appreciation of not only your time but the work that you have invested in this space. We need champions like yourself. This is such an important topic because I think if this gains traction, which I believe it will, but the sooner we can see this occur, the better, where this is a modality that is taught across not only psychology, but all health professionals, those that connect with humans that could have, could be an impactful person, that we don't shy away from these conversations. And the first thing is to say suicidality is not a disease. It's not an illness. It's a great challenge and it's hard to carry, but there's nothing wrong with experiencing these experiences. So, I appreciate the effort and the work that you and your colleagues, and putting all of this together across the world is a hard task. And just thank you so much for your work. And if it was up to me, you wouldn't go into retirement. We'd keep you on the job. So
maybe I won't retire. Actually, I was thinking. I think this is too deep a passion for me to ever let go of. But yeah, we'll see. Just more holidays at the other end.
yes, that's true. But thank you so much, and appreciate your time, and look forward to seeing some of those updates hit the ground as well, particularly at the curriculum level, because I think that's the big impact, and it will start to spread further. So thank you again for today.
No worries. Thanks so much for having me. Thank you.